I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the April 2016 PRS Journal Club podcast. I'm Amanda Silva, a fifth-year plastic surgery resident from University of Chicago, and I'm joined by my fellow PRS resident ambassadors Sammy, Sinno, and Raj Sawh-Martinez. Today, we welcome our guest discussant, Dr. Jeffrey Janis, Vice Chairman of Plastic Surgery at The Ohio State University Hospital. We'll be discussing an article by Roostaeian et al. Out of UCLA entitled Impact of Prior Tissue Expander Implant on Post-Mastectomy Free Flap Breast Reconstruction. The authors reviewed all patients from their institution who had undergone autologous free flap breast reconstruction following failed prostheses, termed tertiary reconstruction, and compared outcomes to a random cohort drawn from patients who had undergone de novo autologous breast reconstruction. Amongst that group, 78% were immediate reconstructions and 22% were delayed. 89 women required tertiary reconstruction in 121 breasts, and they were compared to 89 women who underwent primary reconstruction in 123 breasts. Age, BMI, number of bilateral reconstructions, and number of smokers did not differ between the groups. However, the tertiary reconstruction group was more likely to have had prior radiation, 49% versus 23%. The most common indication for tertiary reconstruction was capsular contracture, and the majority of those patients had undergone previous radiation therapy. The authors found that recipient vessel scarring was about 5 times more likely to occur in tertiary reconstruction cases, and complications requiring operative management were also more common, 17% versus 8%. However, they noted no differences in flap loss or operative take-back rates or in the operative time. Given that tertiary reconstructions were more likely to have had prior radiation therapy, the authors compared complication rates and frequency of vessel scarring in patients within that group who had undergone radiation versus not, and noted no significant differences. In the tertiary reconstructions, the majority of breast skin was salvaged in only 17% of patients. Partial skin salvage was possible in 50%, and minimum skin salvage was possible in 33%. For comparison, in primary delayed reconstructions, the majority of patients had partial skin salvage. The authors stated that alternate flaps other than DEEP or TRAM were more frequently used in the tertiary reconstruction group, which might lead one to believe that these patients had not had adequate tissue to offer an abdominally based autologous reconstruction from the beginning. But they did include SIEA and SCIA and other, which are abdominally based flaps. Based on their experience, the authors concluded that salvage breast reconstruction with autologous tissue after failed prostheses can be safely performed with success rates similar to primary free flap breast reconstruction. However, these procedures may have increased complexity due to recipient vessel scarring, higher rates of prior radiation therapy, and major complications, which warrants appropriate pre-op planning and patient counseling. So I'd now would just open up the board to everyone else to discuss what you think of this paper.
Amanda, that was great. I think I have to shave again. That is that was an extensive review of this paper. That is very thorough and very comprehensive. Again, thank you for inviting me to participate in your PRS Journal Club. This is a really neat concept, and I definitely love the interaction. So let's go to this concept here. We're going to evaluate this paper with a good old-fashioned Roman style thumbs up, thumbs down. Okay, so you don't get to hold your thumb in between. You have to make a choice. You have to commit to whether you're going to keep this paper in your files or whether you're going to throw it away. It's a light switch, not a dimmer. So we'll start with you, Amanda. First, all I want to hear is whether you are going to keep it or trash it.
I would keep it.
All right. Raj, keep or trash?
Trash.
All right. Sammy, keep or trash?
I love Jason, but trash.
Oh, 2 trashes and a keeper. All right, well, let's go in reverse order. I want to hear just one thing, and we'll keep it to, kind of a concise explanation. One main reason. There might be several, but what's the main reason you want to trash it, Sammy?
Well, I think I don't have any major objections with how the study was performed, but this is something that is not news to me. I mean, we do this all the time, and I'm sure Amanda would feel the same way with a lot of heavy breast reconstruction at our program. And we were talking to Bob Allen the other day, did a DEEP for a patient with failed implant-based reconstruction. He says, I haven't put an implant expander since the 80s, and it's been doing, thank God for tissue expander breast reconstruction, because otherwise I wouldn't have a practice. So I think something that I see a lot of and we do all the time.
So, Raj, what do you say? You were trash as well. What say you on this?
Yeah, I think it is very similar to what Sammy said. And, I've done many papers very, very similar, but it's a good review looking at the data and reporting it. But I didn't think there's anything that was really significantly new for me. But similarly, we're high volume of breast reconstruction. And I think, to me, the big take-home was, it's much more difficult to do autologous reconstruction after the radiation. And you have a tissue expander because the vessels are scarred, and, there's a complication profile. That's become sort of intuitive for us as well, like Sammy, I think, was mentioning. So I probably just kind of read it, enjoy it, and then, kind of move on.
All right, so both of you are essentially saying the same thing, which is this is reiterating what you feel like you already knew. But Amanda says we're keeping it. So, Amanda, why are you keeping it?
So I do actually kind of agree with Sammy and Raj in that it's not necessarily anything new. It's intuitive. But I think for patient counseling and be able to tell a patient who comes in your door who has had botched implant reconstruction and wants to get an autologous reconstruction to be able to show them data and show them that we can do this. There may be more complexity. There may be a higher rate of complication, but ultimately we'll end up with a reconstruction that has the same rates of flap loss, same operative time, that it's not going to necessarily put you at much higher risk.
So since you know this paper the best, probably since you're the one who's kind of discussing it, what do you think is the biggest limitation? You're the only one who said to keep it, but what's the biggest limitation, do you think, when you're reading it? What did you want to see that you didn't see, or what do you think at least caused you to hesitate when you were thinking about whether you were going to keep it or not?
Mm-hmm. I think this paper brought up a lot of questions for me. I think there's a lot of data that I would be interested in that isn't necessarily presented in the paper, like how far out were these patients from their implant reconstructions, from their radiation therapy, the fact that also they were comparing it to a combined group of immediate and delayed primary reconstructions. I think that maybe would have even been better to break it up into 3 groups where you have the tertiary, the primary immediate, and then also have primary delayed, because I think that you can't group immediate and delayed reconstructions together.
Yeah, I think you've hit on some important points that I was going to bring up as well. So I think you've read the paper obviously very thoroughly and were able to pick up on that. Let me ask you, Raj and Sammy, you said again, keep it. Trash it. I know you're throwing it away. Did you get anything out of it? One thing. Tell me one thing you're going to do differently because of this paper. And if I don't hear anything as the tumbleweed blows by, then I'll just assume that Bueller is also on the phone call and you got nothing to say. All right? So, Raj, one little baby thing if you can find it.
No, I agree with Amanda. I think on the count, the one thing that does help us a lot with is giving numbers to the problem. So I think you can highlight the complication rates and some of the issues for patients. You can give it to them, this article completely, and say, listen, this is the category you're in. This is why you may have a higher complication rate. It'll help you with discussions pre and post of the roadmap. So I think in that regard, it's sort of invaluable to have those numbers. So I think in patient counseling, for sure, anticipate knowing now even more so, right? Let's say before it would be intuitive to think, okay, well, this is the case that the patient had radiation. This is going to be kind of painful. The vessel dissection may be a little bit harder. There'll be scarring. The vessels may be fibrotic. Now you kind of sort of have in your mind what the numbers are. So I think in that sense it is very useful, and that I definitely take away from that.
All right. Sammy, last word on why you think that you got a little baby pearl out of this thing, if at all.
Exactly what was said. If I have a patient that's come in after failed or unsatisfactory implant-based reconstruction, to be able to say, look, we can do free flap with what we know to be really similar rates of flap loss or needing for take back or even operative time, I think that's a powerful thing to be able to say scientifically and not just say experientially. So I think from that perspective, I think it was a great paper, but just nothing too radical in terms of what we already see so common.
Well, I think the important part in what I've been trying to do without drawing attention to it is the fact that even the people who say trash it can still find some value in it, and even the people who say keep it can still find some issues with it. And I think, that's a very balanced approach and something that your listeners need to hear. Not everything that's published is going to be exceptionally high quality plate tectonic, earth shifts, massive mental framework changes that completely change the way that you do business or that you treat patients. But if you could get even one thing out of the paper that you read, then that might just very well be a worthwhile investment of your time, which is why I think it's important to read the journal in the first place, because I think you can find something in anything. It's just like life. You can learn something from every situation. Sometimes you can learn what to do. Sometimes you can learn what not to do. And I think every paper is probably a microcosm of that. Now,
Jason,
couple of
Jason's texting me right now. He wants to know if Dr. Janis keeps or trashes this paper. What should I tell him?
Well, I was about to say conflict of interest. I got a couple of conflicts to tell you. Number one, I know Jason very well because Jason was the aesthetic fellow in my last year that I was at Southwestern. So I must say, and I also know a couple of the other authors here with Andy DeLeo and Joan Lipa. So I must say that I know Jason, who's the first author on this paper, and so I need to acknowledge that. And the second thing is and maybe as I kind of run through a few things that I noted that we haven't mentioned yet as we wrap up this discussion, is being a PRS reviewer and associate editor for both PRS and PRS Global Open, we all learn to kind of critique papers. And I'm looking at this, and here's a few things that I noticed. Number one, in the method section, they included the CPT code 19364, which is a breast free flap. There's also newer codes that are out there like S2068, which is perforator flap, which usually delineates a deep flap, which is the majority of what this group says that they do. So I wonder if they truly captured their entire patient population, and if so, they should just mention that they've used more than 19364, but also the S codes to capture that. I also want to point out in the results section that the mean follow-up was about 10 months on the prosthesis group, 11 on what they call the de novo group. It's not a huge deal, but the 10 months on the prosthesis group's not a long time. What drew my attention more was the range of 3 to 42 months. Three is on the short side for sure. So I'd almost like to see not only what is the mean follow-up, but what's the median follow-up. See if there's some outliers dragging that down. But 3 months is pretty short. I'd almost say we should exclude some of those. Obviously, you're going to get capsular contracture with radiation, so I think that's something that was discussed in the paper that we already knew. But one other thing I wanted to talk about was this is a large group. Just look at the authors. Look at the number of authors. There's a lot of authors in there that are senior surgeons and people with a wide variety of experience. So this is a cohort of patients treated by a number of different surgeons, and it mentions actually in the paper that the choice of flap was at the discretion of the surgeon and reflected the most appropriate flap for the patient based on available donor sites. But that does introduce some variability. Not only in what the surgeon selected as a reconstructive option and therefore what complications may or may not have existed, but also in the documentation of those operations. Scarring and fibrosis may be noted in the operative report, or it may not be, or it may be in a different way, and just because of the intrinsic variability with a number of surgeons, I think that needs to be taken into account. Also, there's going to be a learning curve associated. I mean, take a look at the years that this patient population covers, and this also goes back to a time you have the advantage, Sammy, of having Bob Allen there, who was doing this really before anybody else when he was at LSU. So, there's a learning curve associated with this, and when they're reporting their total complication rate, I wonder, how does that take into account the learning curve over time, and if there's a surgeon proficiency variation, in fact, in that. And then finally, later on in the paper, it talks about how maybe some of the findings around the internal MAMs were because of what they call compressive forces from the tissue expansion process, possibly due to inflammation, local foreign body reaction, which is managed by the draining lymphatics. I would say that unless you can prove that to me, that sounds theoretical. So, that very well might be true, but I don't know that we have seen definitive proof of that, at least to my eye or ear. So at the end of the day, I definitely think this is a worthwhile paper to discuss, and just wanted to have an intelligent discussion about the pros and cons of what we see. But I definitely commend the author group for putting their experience forward because it's important to learn from that.
Yeah. All right. Great. Thank you.
Thank you so much.